Hi, this is Jeanette Kingsley, and I'm going to give you guys a class on pregnancy-induced hypertension. Hypertension is the same as high blood pressure. It is abnormal systemic vasoconstriction. Hypertension is defined as systolic blood pressure of greater than 140 millimeters of mercury or diastolic blood pressure greater than 90 millimeters of mercury. Chronic hypertension is defined as hypertension that is present before pregnancy or develops before 20 weeks of gestation. Women who have chronic hypertension are more susceptible to acquiring preeclampsia or eclampsia. Hypertensive disorders contribute significantly to maternal and infant morbidity and mortality. These disorders include placental abruption, respiratory distress syndrome, cerebral hemorrhage, hepatic or renal failure, disseminated intravascular coagulation, pulmonary edema, seizures, and intrauterine growth restriction. Pregnancy-related hypertension accounts for 10 to 15% of maternal deaths worldwide and is the second leading cause of maternal mortality in the United States. Pregnancy-induced hypertension is also called gestational hypertension. It is the onset of hypertension without the presence of proteinuria after 20 weeks of pregnancy, but generally develops after 37 weeks. Blood pressures usually return to normal levels within 6 weeks of delivery, with the woman who has gestational hypertension with no evidence of pre-existing hypertension. Pregnancy-induced hypertension can be classified as mild or severe. Women with mild hypertension usually have good pregnancy outcomes. Others will go on to develop proteinuria, thereby changing their diagnosis to preeclampsia. Preeclampsia recurs more frequently in women in their first pregnancy, multifetal pregnancies, ages younger than 19 and older than 40, obesity, and pre-existing medical or genetic conditions such as chronic hypertension, renal disease, diabetes type 1, and collagen disease. The cause for preeclampsia is still unknown, and the current thought is that it's pathological changes that occur in the women is caused by the disruptions of the placental perfusion and endothelial cell dysfunction. So let me explain how this works. Early in the pregnancy, new blood vessels develop and evolve to efficiently send blood to the placenta. In women with preeclampsia, these blood vessels don't seem to develop properly. They're narrower than the normal blood vessels, and they react differently to hormonal signaling, which limits the amount of blood that can flow through them. The increase in blood pressure causes the endothelial cell permeability, which causes the vessels to become leaky and allowing protein to escape. This leads to protein in the urine, also called proteinuria. And as protein leaves the blood, so does water, causing swelling throughout the body. This type of edema is found in the hands and the face and is defined as abnormal edema in pregnancy. Further, intravascular protein and fluid loss ultimately leads to loss of plasma volume, causing poor perfusion, resulting in increased blood pressure. There's three cardinal signs of preeclampsia. The accurate measure of the blood pressure is essential in the early detection of hypertensive disorders. Edema is assessed for distribution, degree, and pitting. Dependent edema is edema on the lowest parts of the body, like the feet and legs, and this is deemed as normal in pregnancy. However, independent edema of the hands and the face is considered abnormal. Proteinuria is defined as concentration of greater than 30 milligrams per deciliter in at least 2 random urine specimens collected at least 6 hours apart. So the physical assessments is you're going to assess for deep tendon reflexes because they reflect the balance between the cerebral cortex and the spinal cord. And you're going to look for hyperflexia of +3 and +4. You're going to listen to the heart and lungs for adventitious sounds. So basically you're listening for fluid overload. And then you're also going to conduct neurological assessments that include the EOM to test for nystagmus, perla, and assess for clonus. A very irritated central nervous system becomes apparent after +4 deep tendon reflexes. If the patient has preeclampsia, there's a chance that they can become eclamptic. So eclampsia is the onset of seizure activity or coma in a woman with preeclampsia. Eclampsia signs and symptoms include persistent headache, blurred vision, dizziness resulting from cerebral edema, severe epigastric or right upper quadrant abdominal pain, and altered mental status. However, convulsions can appear suddenly without warning in a seemingly stable woman with minimal blood pressure elevation, so make sure you just look out for that. Nursing actions during convulsions are directed towards ensuring that the patient has a patent airway. So we're going to remember our ABCs, airway, breathing, and circulation, and also client safety. We're going to note the time of the onset and the duration of the seizure. The immediate care is that we're going to call for help. We're not going to leave the bedside of the patient. Make sure that the rails are up and the patient is on bed rest. We're going to darken the environment to reduce the stimuli. Then we're going to start them on magnesium sulfate since it's a preferred treatment for seizures. And we may be able to give them some hypertensive medication, and we're going to go ahead and assess the uterine activity. So magnesium sulfate is the drug of choice in the prevention and treatment of seizure activities that are caused by severe preeclampsia or eclampsia because it relaxes the central nervous system. It's administered intravenously with the initial dose of 4 to 6 grams that is infused over 15 to 30 minutes. It's followed by a maintenance dose. Magnesium sulfate works by relaxing the smooth muscles. Vital signs should be done every 15 to 30 minutes. And in case of magnesium toxicity, watch out for respiratory depression, decreased urine output, hypotension, hypoflexia, and sudden decrease in the fetal heart rate. Again, it's a CNS depressant, or it relaxes the CNS, so patients can become comatose. And if this occurs, the first step of the nursing intervention is to stop the magnesium sulfate and be prepared to give the antidote calcium gluconate as PRN protocol. So the only way to cure preeclampsia is delivery of the baby in the placenta. Reduced physical activity and taking high blood pressure medication can lower the blood pressure, but it's not going to completely stop preeclampsia or worsening or completely reduce the risk of complications. And that concludes my presentation. Thank you for listening.